Peggy said, my name is Adrienne Lynch, and I have been living a diagnosed life with lupus since 2009. Probably had lupus since I was probably about 7 years old. But prior to getting diagnosed, I found myself unable to walk. My eyes had betrayed me. There was just so much going on. And after diagnosis came the treatment, which I found to be just as bad or sometimes worse than actually having lupus. I was on toxic medications for my kidneys. I was pumped up with steroids, which forced me to put on a bunch of weight. And I certainly like to wear small clothing, so that was a challenge for me. It also affected my career. At the time, I was a producer at a major television network, and I had to make a decision, you know, whether or not I was going to focus on my career or focus on my health. And of course, my health won out, and I decided to start my own company so that I was able to manage my schedule, manage my doctor visits, and really work around anything that may have happened with my life. So I just urge everyone here who is in a position to change policy, to affect research, to hear everything that we're saying here and just push forward and keep working, and don't give up on things that don't give up on this process here. So someone who hasn't given up on us and who is working really hard for us is Dr. Betty Diamond. She is the investigator and head of the Center for Autoimmune and Musculoskeletal Disease at the Feinstein Institute for Medical Research, North Shore, LIJ. She is a leader in lupus and patient care and is going to speak about the effect of health and racial disparities in lupus, and I personally thank you for that. Thank you.
Well, I'm delighted to be here because, as those who have known me for many years know, this is something I feel quite passionate about. And my take-home message is there are health disparities in lupus, as in so many diseases, and we can and must do something about it. So it's not surprising that when one thinks about health disparities, there are those we can address as health professionals, those we can address as citizens, and those, like we've heard, genetics, which are immutable. I think we all know that the demographics of the country are changing, and that there are going to be more what we now call minority populations in America over the next decades, more African Americans, more Hispanics. And why is this important when we talk about lupus? Well, we've already heard that women are much more likely to get lupus than men, and we've also heard that African Americans, Hispanics, and Asians get more lupus than Caucasians do, 3 to 4 times more likely to develop lupus. So the changing demographics is an issue because if we can't treat or we don't treat lupus well in that population, we have a growing problem. So why does one say there's a disparities problem? Why is this not just genetics? Well, we know that genetics is an important player in why a person develops lupus, why a person has a risk for getting the disease. But we also know that once you have the disease, how you do with that disease is not determined by genetics. It's determined by poverty and what your disease activity was at the time the diagnosis was made, how sick you were before you came to the attention of the medical community. So these are not genetic problems. These are societal problems. And, you know, there are risk factors that aren't genetic. In fact, it's really staggering we talk about these diseases, and even a disease that affects 1.5 million people, which is the upper estimate now for what the incidence of lupus is still a reasonably rare disease. But autoimmune diseases in general affect 8% of the population. And in the 1997 statistics, there were more people with autoimmune disease in this country than with cancer. So this is not rare autoimmunity. This is very prevalent, and we know that the genetics of autoimmune diseases have much in common, and we know risk factors have much in common, non-genetic risk factors. So this is an area that we need to pay attention to. And what I'm showing here is that autoimmunity is, in fact, increasing in incidence for essentially all autoimmune diseases. And I show you data from a study on diabetes. And the reason I show diabetes is there's nothing subjective about the diagnosis of diabetes. Your blood sugar is high or it isn't. And there's nothing occult about the diagnosis of diabetes. This is a readily accessible test. This is easy. And you can see over 50 years, there's a fourfold increase in incidence in diabetes. And so the incidence of autoimmune diseases is going up worldwide. There are many hypotheses for this. There's the hygiene hypothesis. We're too clean. We don't have enough parasites in our life. There's estrogen hypothesis that, in fact, the drinking water that we all have is full of estrogen. Maybe it's making for a more mellow country, but it may also be making for a more autoimmune country. Vitamin D deficiency is rampant, and we all know about the obesity epidemic. And so here I show you one of the risk factors for developing autoimmune disease. And this is many autoimmune diseases, and that's vitamin D deficiency. So this is not to say that once you have an autoimmune disease, restoring vitamin D will get rid of it. It's not so simple. Once you perturb the immune system and you make it veer off course, you need more than vitamin D to get it back on course. But it is a risk factor. And what you see here is that African Americans and Hispanics are much more likely to be vitamin D deficient than Caucasians in our population. And the degree of vitamin D deficiency correlates with a disease activity score called SLEDAI. So minority populations are not just genetically more at risk to develop disease, but the environmental triggers that we know about that contribute to risk for autoimmune disease are more prevalent in minority populations. So now you have lupus. We know renal disease, kidney disease, as you've heard, is a major cause of morbidity and mortality in lupus. So 60% of lupus patients will develop kidney. It's higher in African Americans. And once you have kidney disease, you may go on to what's called end-stage renal disease. And 50% of end-stage renal disease in lupus is in African Americans, though they account for only 25% of people affected with lupus. So we can see that there is a problem in controlling the disease, in managing the disease, in one of the more devastating aspects of the disease. So this is just showing you it's not just going on to end-stage renal disease, it's survival. And that if you have lupus nephritis, if you're Caucasian, you'll do best. If you're African American, you'll do worse. If you're Hispanic, Asian, whatever, you'll do intermediately. What is the treatment for end-stage renal disease? Well, the treatment for end-stage renal disease is dialysis, which is an incredibly limiting way of life, or transplant. So African Americans are the least likely to receive transplants, then Hispanics, then Caucasians. So this is a problem not just of the medical community. This is actually a problem within the African American community itself, and requires more education and more outreach and more advocacy there, because African Americans are the least likely to be organ donors, either living organ donors or cadaver organ donors, either willing to donate organs after death to somebody who needs it. So there are multiple levels at which we need advocacy and we need education. And I think on the bottom is a devastating comment on our healthcare system, that having Medicaid as your insurance is a risk factor for not getting an organ transplant. So you get your organ transplant. What happens then? You can see that African Americans with kidney transplants have more rejections and do worse than others. Why is this? Well, we're back to our societal issues. Poverty. Hypertension is a problem in organ transplants and kidney transplants, and we all know from multiple news articles that hypertension has to be treated differently in African Americans than in whites in America, and it is less well controlled by physicians and patients in concert than in whites. And the longer time till you get an organ transplant makes it less likely that the organ transplant will succeed. So the lack of organ donors, because of the genetic differences that exist, an African American is more likely to need another African American as their organ donor. What about heart disease, which accounts for 1/3 of the deaths in lupus? Well, hypertension and diabetes are contributing factors to the heart disease, and medical management of hypertension and diabetes is better in Caucasians than in African Americans and Hispanics. Access to cardiac catheterization, even in this day and age, even after a director of the NIH made cardiovascular disease in women the platform on which she stood and directed the nation, women are much more less likely to get cardiac catheterization than men, to determine whether some of the symptoms they are experiencing are related to heart disease or not. And minority populations are less likely to be recommended to go for cardiac catheterization than white individuals in this country. And physicians are less likely to discuss exercise and diet with African American patients than they are with any other patient group. And interestingly, this is true for African American physicians as well as for white physicians. So we cannot target our advocacy and educational efforts to one group only. We all need to be more aware and do better. So what are the factors related to outcome? Well, there are patient issues. There's the need to live a healthy lifestyle. There's something called self-efficacy, which is the sense that a patient has some control over their illness, that they're involved in making decisions, that what they do can affect their outcome, that they're not powerless victims in their life. And there's adherence to therapeutic regimens, which we know is a problem even to take a 10-day course of antibiotics. And imagine if one was taking a lifelong course of 35 pills a day, which of us would do it? There are physician issues, willingness to engage patients in therapeutic decisions and to empower patients so that they, in fact, can experience self-efficacy, willingness to discuss lifestyle issues so that one takes on diet and exercise, which we know can do wonders for diabetes and hypertension, and cultural competency. So one does this in a way that doesn't make individuals feel misunderstood or disrespected. And then there are societal issues. And Adrienne mentioned policy concerns. This is access to health care. This is rampant poverty in America. And this is a lack of education that gives one the means to learn about one's disease and to be thoughtful about one's disease. So perhaps the easiest group to address in all of this are physicians, because there are times when we have them in one place and we have command of their ears, if not their brains. And so physicians operate under a lot of misconceptions. As I started working in this area, really driven by the Lupus Research Institute to start thinking about health disparities in lupus, one of the most shocking statistics to me was what's on top, that 63% of physicians can possibly think that the healthcare system has no racial or ethnic bias, compared to a much better informed or more honest public that thinks it's where 43% think there is no bias. And when one goes to African Americans, it's 25% that believe there is no bias. Physicians also believe that minorities are less likely to engage in clinical studies and clinical trials. And we know that there are differences in response to medications. So while research may take us to therapeutic interventions, finding the right therapeutic intervention for African Americans or Hispanics or Asians is going to require that African Americans and Hispanics and Asians be part of clinical trials, because what is best for Caucasians may not be best for each of these other groups. And physicians are less likely to ask minorities to engage in clinical trials, but the data are that they engage, and once they have engaged, they are as likely as Caucasians to engage in a second clinical study or a second clinical trial. Their experience in engaging in clinical research and clinical trials is as good and as positive as anyone else's. And we all know that health advances may start with fruit flies and start with yeast, but it ends with a partnership between patients and physicians and the taxpayer dollars to advance an agenda for specific diseases and specific populations. There's also a bias that people have that minorities engage in much less healthy activities. But the United States keeps records of this, keeps records of who smokes, keeps records of how many fruits and vegetables you take in every day, and whether you get your immunizations or not. And in fact, the data are that that's no different for African Americans than for Caucasians. And it's really poverty that leads you to McDonald's. It is not race that leads you to McDonald's. And then there is this sense that minorities are unable or unwilling to participate in their own health care. And some of this is the thought that they distrust the healthcare system and so won't engage it until the need is dire or are suspect about recommendations. And it turns out that that's not so very true either. That if you look at who in an emergency room population comes to a follow-up visit, there's no statistical difference among groups in who will return for their follow-up visit. And if you find out why those who did not return, why they didn't return, you get to the crux of the issue, that the Caucasians didn't come back because they feel better. And while that may not always be a good reason not to come back, sometimes it is, but minorities don't come back because of difficulty in making follow-up appointments. And the causes for that are multiple, from difficulties getting childcare when they go back, from difficulties getting transportation, to healthcare system flexibility in scheduling appointments. There are numerous problems there. So what's the conclusion from all of this? Well, the conclusion has to be that we can do better, that in fact, minority populations do not have a worse outcome from their lupus because of their genetic endowment. And in fact, even their risk of developing lupus is part because of their genetic endowment, but part because of other triggers that may be important in the combination of genetics and environmental triggers that lead you from a predisposition to a frank disease may be more prevalent in minority communities. And some of these issues can be addressed within the patient and physician bond and patient and physician advocacy groups and patient and physician education, like hypertension, diabetes, self-efficacy, access to organ donation, cardiac catheterization, engagement in clinical research and clinical trials, lifestyle, cultural competency, and some of these are societal issues which we all need to address as citizens, because we need to recognize that stress, poverty, access to health care, these are all public health issues. And in the end, we pay for not addressing them early on. So the Institute of Medicine has been interested in this, has recognized that healthcare disparities is a big problem, and has come up with guidelines on informing healthcare professionals on the nature and extent of disparities, using treatment guidelines to get away from these biases, these unconscious biases, to have on your checklist. Did you ask this patient to engage in clinical research? Did you offer this patient access to a clinical trial? Patient education programs, and to include for professionals in their metrics of how they're performing, how they're doing in terms of racial and ethnic disparities. There's a cost to inactivity, a human cost to the individual, as we've heard, to families, and as we've heard, this is a disease primarily of women in their childbearing years, so to young children who are innocent victims in this process, as are the patients themselves. There's an economic cost, but the good news is this is a situation where doing the right thing is also cost effective. So let's hope we all leave and do the right thing.